Hi everyone, I'm Dr. Francesco Prada. I'm a neurosurgeon in Milan. I will be talking about microbubble distribution and administration protocols for blood-brain barrier opening for brain tumors. There are several devices that have been already employed in the clinic for blood-brain barrier opening. We have MR, magnetic resonance guided systems. We have implantable devices. And we have external navigated single element devices. They have one thing in common, in which they have been employed in all cases in conjunction with microbubble administered as a bolus. There is another way to administer microbubble, which is through an infusion. And this is a recent paper from Rajiv Chopra and colleagues, which has been published in scientific reports, in which they showed clearly that BBB opening is feasible and effective even when using infusion of microbubbles. And staying within a certain limits of amount of microbubble, no damage is it's a harmful procedure. But it is important to understand not only how the microbubble are administered and what changes when we use bolus or injection, but also how the microbubbles go and how do they distribute in the brain and how do they behave in the presence of a brain tumor. So to better understand this, I think it would be helpful to start from where the microbubble were conceived for ultrasound imaging, and eventually can go back into the OR as well. This is a paper published almost 10 years ago by the European Federation for Ultrasound in Medicine and Biology, trying to define the different options of administration of microbubble. We have in fact the bolus and the infusion. In this diagram, you can see how when we inject microbubble as a bolus, we tend to have at the arrival of the microbubble, the so-called wash-in phase. Then we have a peak phase. Then the microbubbles start to circulate through the body, and they wash out from the organ since they reach a slowly decreasing steady state, which is where usually we start BBB treatments. In this diagram, instead, we can see how microbubble reach a steady state, and which is stable throughout the evaluation if we use an infusion modality. This is a paper published by Quaya and colleagues in 2015, and they were the first to use an automatic power injector in humans, and they clearly showed that when we inject bubble as a bolus, we have a peak and a slowly decreasing steady state, whereas with the infusion, the steady state is also the so-called the plateau is reached in a later phase, but it remains stable. It is also important that using the same amount of microbubble, the duration of the microbubble in the bloodstream is twice as much as that we obtain with a bolus injection. So this would allow for prolonged sonications. On the other hand, it is interesting to see how the difference between structure is highlighted at the time of the peak. In this study, conducted always with contrast ultrasound for breast tumors, Sarak and colleagues showed that the peak of enhancement is much stronger with the bolus. The lesion is much more highlighted with the bolus compared to the brain surrounding parenchyma. So I would like to share also some of the experience about quantification of microbubble in the brain, infusion of microbubble and BBB opening, and the possibility to have a non-invasive biomarker for microbubble distribution. Here in the video, you can see how microbubble are able to highlight and how they accumulate in brain tumor compared to the surrounding brain here, and they can be used for surgical guidance. But the information that we can obtain during surgery, which means we can see the microbubble, we do not only listen to them, we can see them. This information that can be helpful for treatment planning and provide feedback for BBB opening. So for example, when we talk about glioma, we can see how high-grade glioma in the upper row tends to have a higher degree of enhancement and a faster peak of enhancement compared to low-grade glioma. So we can differentiate brain tumors according to the microbubble distribution. And we can also obtain quantitative measurements to understand the behavior of microbubble in the brain. We studied a large cohort of patients, and we found that consistently different areas of the brain have different amount of microbubble. Here are some examples. For white matter structures, they tend to have different amount of concentration of microbubble. For example, the corpus callosum have less bubble than the periventricular white matter. We have cases in which brain structures such as the basal ganglia have the same amount of microbubble as brain tumors, anaplastic glioma. And also it is interesting to note how within the same tumor we have different areas with different amount of microbubbles. Specifically, the core of the tumor has higher here, have more bubble, which is closer to the artery, have more bubble compared to the periphery or the necrotic area. Here, this is an example instead of testing infusion of microbubble in an in vitro ex vivo isolated guinea pig, which is perfused with a microbubble, and then it's sonicated with planar wave therapeutic ultrasound while simultaneously performing contrast enhanced ultrasound. Here in the video you can see an axial view of the brain with a microbubble moving freely across the brain. Then we sonicate the area, and you can see that there is a reduction in a qualitative reduction of the microbubble, followed by a replenishment of the area. And the sonicated area tends to replicate what we see in the video in its shape. It is interesting to note that we didn't have any side effect, but the intensity also of the microbubbles tends to reflect the amount of microbubble as seen on contrast enhanced ultrasound. In other words, also we performed a quantitative evaluation during the sonication. You can see here at the beginning, before starting the sonication, we have a plateau, which the blue line is the non-sonicated area, the red line is the sonicated area, which tends to decrease according to the microbubble disruption or disappearance. It's interesting also that it would be helpful also to have a non-invasive biomarker of microbubble distribution, considering all that. We're performing a study comparing two perfusion modalities. One is microbubble perfusion, the other one is MRI perfusion. We are doing such using fusion imaging with intraoperative data. This is a case of a meningioma, it's not a glioma. However, it is interesting to note how analyzing the same region of interest, namely the brain tumor, an artery as a reference, and the white matter, the shape of the curve is not exactly similar because the two contrasts, they behave differently. One is endovascular, the other one is extravasate. But the distribution within the same region, at the peak at least, is superimposable. So ideally, MR perfusion could become a biomarker for, if validated, can become a biomarker for MB distribution. In conclusion, the quantitative analysis of microbubble distribution is feasible and provides information on how microbubble behave in the brain. Different brain structures and lesions have different microbubble dynamic concentrations, of course. The bolus versus infusion, it's for sure something that should need more research and understanding. And we also believe that the development of non-invasive biomarker and 3D mapping of microbubble distribution would be helpful to tailor BBB microbubble mediated treatment planning. Thank you for your attention.